Hi, my name is Denise Lauterbaugh, and I'm going to be talking to you today about doing blood gases and reviewing them in 3 easy steps. So hopefully this will be much easier for you. Our learning objectives today are to identify normal blood gas values and to identify normal cord gas values and to be able to interpret the cord blood gases and identify those patients who might be in need of cooling. So there's 3 questions that you have to ask about blood gases. And the first question is pretty simple. What is wrong with the pH? Is it above 7.40 or is it below 7.40? Is it acidotic or is it alkalotic? That's the question you have to find out about the blood gas. Second question, which system caused it? There's 2 systems, respiratory and metabolic. One of those had to have caused it, and the other one's reacting to it. Although you can have a combined, we'll talk about that later. So what is the body doing about it? What type of compensation is the body trying to do? Has it done any compensation or is it working towards compensation? But before you can answer any of these questions, you have to understand how the body achieves homeostasis. Homeostasis is the human body's ability to regulate itself to maintain a stable, constant condition called homeostasis. So with blood gases, the body alters the carbon dioxide levels and the bicarbonate levels, working to always keep a pH of 7.40. So a pH of 7.40 is homeostasis. And I know we talk about 7.35 to 7.45 as a normal range, but 7.40 is exactly homeostasis. So when your pH is balanced, as seen in this photo, the carbon dioxide coming out from the tissues, it's being vented by the lung. The renal system is getting the bicarbonate going, and it either buffers it or produces it depending on what is needed by the body. And that maintains that neutral pH of homeostasis. So the second question that you have to ask yourself when looking at blood gases is what is wrong with the pH? If it's not 7.40, there is something wrong, even if it's in an acceptable range of 7.35 to 7.45. So in order to understand this question, you have to first understand all of the normal values of your pH, your PCO2, and your bicarbonate. And the human body adjusts the carbon dioxide levels and the bicarbonate levels to maintain the pH of 7.40 at all times. That's called homeostasis. That's what your body works for. So what is wrong? Let's talk about the pH first. First question, what is wrong with the pH? The pH is a measure of acidity or alkalinity of any fluid. And in the human body, this measure is 7.40 for homeostasis. We know that normal range is considered to be 7.35 to 7.45. Any pH less than 7.40 is considered acidotic. And any pH greater than 7.40 is considered alkalotic. So which system caused the issue? There's 2 systems that can cause the issue, respiratory and metabolic. We're going to talk about both of them. The respiratory system exchanges carbon dioxide through the lungs. Humans breathe in oxygen and we exhale carbon dioxide, hopefully. So if you're thinking of a respiratory system, then you're thinking carbon dioxide. If you're thinking carbon dioxide, you're thinking respiratory system. Carbon dioxide is a byproduct of our cellular metabolism. The CO2 is then carried through our bloodstream on the hemoglobin and exhaled through the lungs. The carbon dioxide has an inverse or opposite relationship with the pH. As the carbon dioxide in the blood increases, the pH will decrease, becoming more acidic. As the carbon dioxide decreases in the blood, the pH will increase, becoming more alkaline. The normal range for PCO2 is 35 to 45. So if you're thinking about carbon dioxide as the cause, think respiratory. Metabolic. The Metabolic is the breakdown of foods into energy within the cells of our bodies, and the metabolic control is our kidneys that balance our water, our acids, our bases, which is also our pH, and our ions and salt in the blood. So if there's something wrong with the metabolic or bicarbonate, you want to think metabolic, or if you're thinking metabolic, you're going to think about bicarbonate. So bicarbonate is an alkaline buffer, which helps to maintain normal pH in the blood. And a normal bicarbonate is between 22 and 26. Bicarbonate has a direct relationship with the pH. So if the bicarbonate's going up, the pH is going up, becoming more alkaline. And when the bicarbonate, which is an alkaline buffer, goes down, the pH is going to go down and it's become more acidic because there's less alkalinity. So if you're talking about bicarbonate, you want to think a metabolic component. Or if you're thinking metabolic, you want to think bicarbonate. Now there's another thing that we look at on blood gases. It's called base excess or deficit, and it's really another measurement of the metabolic component. The base excess or deficit is used for the assessment of the metabolic component of any acid-base disorders. And it shows us whether the patient has a metabolic acidosis or a metabolic alkalosis, and how bad it is in relationship to the metabolic component or the bicarbonate. So the number of this base excess or deficit indicates the amount of bicarbonate that is in excess in our blood or an insufficient level in the blood. So that's where you get the negative base deficits. So we talked about what is wrong with the blood gas. If something's wrong with it, you're going to look at the pH to decide if it's acidic or alkaline. We're going to talk about which system caused it. So if your body is not at 7.40, then the body is out of homeostasis and something in the body caused this to happen. So you got to look at that PCO2 we talked about, and you got to look at the bicarb for clues. So first, we'll talk about what is wrong with the pH. If it's acidotic, if it's less than 7.40. Acidosis occurs when there's too much acid in the blood or not enough buffers, which is the bicarbonate in the blood, to balance out that pH. Acidosis is quantified by a pH of less than 7.40. The cause of this may be respiratory if the PCO2 is high, or it could be metabolic if the bicarbonate is low, or it can be combined if both the CO2 is high and the bicarbonate is low. An acidosis in the blood is an acute change. The body has not had enough time to try and compensate to achieve homeostasis. So which system caused the acidosis? First, we'll talk about a respiratory acidosis. A respiratory acidosis is an acidosis that is caused by carbon dioxide levels. This can occur when the patient's lungs are unable to excrete carbon dioxide, or any event that causes hypoventilation can cause this, such as a trauma, respiratory disease, an overdose of medication, birth asphyxia, etc. Acidosis means the pH is less than 7.40. What caused it for a respiratory acidosis? A PCO2 that is high. This is what a blood gas with a respiratory acidosis would look like. A pH of 7.32, which is acidotic. A PCO2 of 68, which is high and is acidotic. And a bicarb of 24, which is normal. This is an acute change to the patient. The body has not had time to compensate or to try to achieve homeostasis because the pH is not within normal range. So respiratory acidosis looks like this on the scale. So what would the body be doing about it? How does the body compensate to achieve homeostasis? The body's going to compensate by adjusting the way that the patient breathes and the amount of bicarbonate that they excrete to maintain homeostasis for the patient. The body will never overcompensate, never ever. So this is kind of how compensation happens. Normal is 7.40, normal range, 7.35 to 7.45. And when it goes to acidosis, less than 7.35, then the renal function starts to kick in to try and compensate. The patient will try to breathe faster. The patient will try to breathe deeper, depending on their neurological abilities. If the pH is greater than 7.45 and is alkalotic, then the patient will breathe slower, they'll breathe more shallow, their body will try to dump some bicarbonate. So that is how compensation happens. So what does metabolic compensation for a respiratory acidosis look like? If respiratory acidosis occurs, then the kidneys will work to excrete bicarbonate into the bloodstream until the pH is within a normal range to maintain homeostasis. So it usually doesn't get the patient to 7.40, but it will get them back to the 7.35 to 7.45, which is where we like them to be. A compensated respiratory acidosis will have a pH that's still on the acidotic side. So it's going to be less than 7.40. An example of this is a pH of 7.35. That PCO2 is still high at 68. So there's a lot of acid, but the bicarbonate has kicked up and it's now 40. So it's balancing it out. It's compensating for the respiratory acidosis. Renal compensation for a plasma bicarbonate is up to 3.5 milliequivalents for each increase in 10 of TOR in the PaCO2. So that is what you should see with a metabolic compensation. So now we're going to talk about metabolic acidosis instead of respiratory acidosis. So metabolic acidosis is an this is caused by the metabolic system, and this can occur if the patient excretes too many buffers and the kidneys are unable to produce enough bicarbonate fast enough to replace them. So there's not enough buffers in the body to balance out the acid. The loss of bicarbonate can result from kidney failure, vomiting of the patient, diarrhea, or administration of diuretics. Remember that acidosis means a pH of less than 7.40. And metabolic means a bicarb of less than 22. So an example of this blood gas would be a pH of 7.32, a PCO2 of 40, and a bicarbonate of 18. Just another visual of a metabolic acidosis. So what is the body going to do about it? How does the body compensate for a metabolic acidosis? Well, it uses respiratory compensation. So if the metabolic acidosis occurs, the lungs will try to increase the respiratory rate of the patient to blow off some additional CO2 to balance out the pH. Usually here you will see a rapid respiratory rate of the patient, almost like they're panting for air. A compensated metabolic acidosis will still have a pH that's on the acidotic side of the 7.40. So less than 7.40, but greater than 7.35. For example, a pH of 7.36, PCO2 is low at 32, trying to compensate because the bicarb is low at only 16. So the bicarbonate is too low. There's not enough base for the acid. So the body is trying to excrete some of the carbon dioxide, which is acid, so that the pH is compensated. There are two different types of metabolic acidosis. You really need to know about both of them. There's metabolic acidosis with a normal anion gap. And this can be due to longstanding diarrhea, ureterosigmoidostomy, pancreatic fistulas, renal tubular acidosis, intoxication, renal failure. Those are all normal anion gap metabolic acidosis. But you can also have metabolic acidosis with an elevated anion gap. This is going to be seen when your patient has lactic acidosis, ketoacidosis, chronic renal failure due to accumulation of sulfates and phosphates and uric acid, or intoxication with other types of things like ethanol, methanol, formaldehyde, ethylene glycol, toluenes, sulfates, and metformin. And if the patient has rhabdomyolysis, those are all elevated anion gap metabolic acidosis. So now we're going to move on to what is wrong with the pH alkalosis. And alkalosis occurs when there is not enough acid in the body or there's too many buffers. Alkalosis is quantified by a pH of greater than 7.40 because 7.40 is homeostasis. This can be caused by respiratory, having a carbon dioxide level that is low, metabolic, having a bicarbonate level that is high, or combined, having both a carbon dioxide level and a bicarbonate that are out of range in the alkalotic sites. So an alkalosis with a pH greater than 7.45 is an acute change to the patient because the body has not had enough time to compensate and try to achieve homeostasis. So we're going to talk about respiratory alkalosis first. A respiratory alkalosis is an alkalosis caused by the lungs, by a patient hyperventilating. They're breathing too fast, they're breathing too deep, and they're going to blow off carbon dioxide levels. An alkalosis means a pH of greater than 7.40. And what caused it with a respiratory alkalosis is a CO2 of less than 35. And here's a lovely little visual of that on the scale. So what is the body doing about it is the second question. We know it's a respiratory alkalosis. Metabolic compensation with respiratory alkalosis occurs because the CO2 is too low and the pH is too high. The kidneys will begin to work to excrete bicarbonate from the body through the urinary tract. If the ABG is compensated, the pH will be on the alkalotic side of 7.40. So it's going to be greater than 7.40, but less than 7.46. So within the normal range. For example, a gas of metabolic compensation of a respiratory alkalosis would be a pH of 7.42, a CO2 of 30, and a bicarbonate of 18. So which system caused it? Now we're going to talk about a metabolic alkalosis. A metabolic alkalosis is usually due to a loss of acid due to urine, stools, or vomiting. And it's a transfer of the hydrogen ions into the cells. So giving excessive bicarbonate administration or excessive diuretic treatment, you can get a contraction alkalosis. Alkalosis means a pH of greater than 7.40. Metabolic means that the bicarb is greater than 26. There's just too much bicarb. So for example, we have a pH of 7.48, PCO2 of 40, and a bicarb of 28. That is a metabolic alkalosis. And here is a visual example of it. So what is the body doing about it? Notice that compensation is in the same direction as the acid-base disturbance. So respiratory compensation for a metabolic alkalosis occurs by the lungs trying to compensate. They slow down the respiratory rate and they allow the carbon dioxide levels to rise. A compensated metabolic alkalosis will have a pH on the alkalotic side of 7.40, but less than 7.46. For example, a pH of 7.44, a PCO2 of 48, and a bicarb of 30. You can have prolonged metabolic alkalosis as well. The prolonged metabolic alkalosis is usually due to a decrease in renal perfusion from dehydration, cardiac failure, or cirrhosis. Also, you can have it from chloride depletion, so vomiting or use of loop diuretics. So we covered ventilation and compensation, and now we need to cover oxygen. So oxygen is transported to the blood in two forms: oxyhemoglobin, which is your SaO2, and also dissolved in the blood, which is your PaO2. Oxyhemoglobin, or oxygen riding on the hemoglobin, accounts for about 97% of the oxygen in your blood. And a normal oxyhemoglobin saturation should be greater than 95%. The SaO2 alone does not tell us how much oxygen is in the blood. For that, we need to know the hemoglobin content. So the PO2 is the partial pressure of oxygen in the plasma. And the remaining 3%, remember we said 97% was the SaO2, the remaining 3% of oxygen molecules are dissolved into the plasma itself. And as oxygen dissolves into the blood, it attaches to the hemoglobin until they're 100% saturated. But more oxygen can still dissolve into the blood, making the PaO2 climb rapidly after that. So on 100% oxygen, the PaO2 could reach 600 torr. Partial pressures of oxygen can be measured in any blood vessel. The PaO2, or arterial blood, usually has 70 to 80 torr in adults and 50 to 70 in preemies. The partial pressure of venous oxygen in the venous blood is 35 to 45 torr, and several factors determine the PVO2: your carbon dioxide levels, your oxygen consumption, your hemoglobin levels, and your SaO2. And you can have a capillary PaO2, PCO2, but it's of little value in estimating oxygen, so we don't use it. So let's go through this blood gas. We have a pH of 7.32. We have a PCO2 of 50. We have a PaO2 of 50. We have an oxygen saturation, or SaO2, of 80%. And we have a bicarbonate level of 26. So first question, what is wrong with the pH of this patient? Well, the pH is less than 7.40. So it's outside of homeostasis and it's acidotic. What's the body doing about it? The bicarb is normal. It's 22 to 26. The CO2 is acidotic. The CO2 of 38 is acidotic. The pH is acidotic. Therefore, the imbalance is considered a respiratory acidosis. The bicarbonate is within the normal range of 22 to 26, while the pH is not in the normal range of 7.35 to 7.45. So there is no compensation. The PaO2 and the oxygen saturation are low, indicating the patient has hypoxemia. So the diagnosis for this ABG is uncompensated respiratory acidosis with hypoxemia. Let's do our second blood gas. The pH of 7.26, a PCO2 of 38. A PaO2 of 76, and a bicarbonate of 17, and an O2 sat of 90%. So I want you guys to think about this first. What is wrong with the pH? The pH is acidotic. It is less than 7.40. So what is causing it? The bicarbonate is acidotic because it is less than 22. So the bicarbonate is acidotic. Therefore, the imbalance is a metabolic acidosis. The PCO2 is in the normal range of 35 to 45, while the pH is not in the normal range of 7.35 to 7.45. So because it's not in the normal range, there is no compensation. The PaO2 and the O2 sat are borderline, indicating mild hypoxemia. So the full diagnosis for this ABG is an uncompensated metabolic acidosis with mild hypoxemia. Third ABG, pH 7.38, PCO2 58, PaO2 90, and the bicarbonate is 34, and the O2 sat nicely is 96%. So what is wrong with the pH in this? The pH is on the acidotic side, less than 7.40, but it is within a normal range. The CO2 is acidotic. It is greater than 45. The bicarbonate is alkalotic. It is greater than 26. So diagnosis for this. The CO2 is acidotic, even though it's within the range. Therefore, the imbalance is a respiratory acidosis. The bicarbonate is alkalotic, and it's causing the pH to be within the normal range, 7.35 to 7.45. Therefore, there is a metabolic compensation. Those kidneys have been working. The PaO2 and oxygen saturation are in a normal range. So the full diagnosis for this ABG, because the pH is between 7.35 and 7.45, means that it is a compensated respiratory acidosis with normoxemia because the oxygen levels are normal. Here's another one. pH is 7.45. PCO2 is 47. PaO2 is 100. The bicarbonate is 40. And the O2 sat is 100%. So what is wrong with the pH is our first question. The pH is on the alkalotic side of 7.40. So it is alkalotic. The bicarbonate is alkalotic. It is greater than 26. The PCO2 is acidotic. It is greater than 45. So the bicarbonate is alkalotic, greater than 26. Therefore, the imbalance is a metabolic alkalosis. The PCO2 is acidotic, but the pH is within a normal range, which means that there is compensation. So we will say that there is respiratory compensation for the metabolic alkalosis. The PaO2 and the O2 saturations are within a normal range. So the full diagnosis for this ABG is compensated metabolic alkalosis with normoxemia. Now, that's not it. Sorry, lecture's not over yet. There are other blood gas numbers that you have to understand as well. Hematocrit is the percent of red blood cells in the blood. In premature infants, the hematocrit is usually elevated. They need that extra hematocrit. Elevated hematocrit in neonates can be related to chronic hypoxia, elevated levels of EPOGEN, dehydration of the patient, or erythrocytosis. A lowered hematocrit in neonates can be relative to a hemorrhage, inadequate iron intake, chronic kidney disease, hemolysis, vitamin B12 deficiencies, but most often excessive blood draws. Hemoglobin is the protein molecule in the red blood cells, which helps us to carry oxygen and return carbon dioxide to the lungs. In newborns, hemoglobins are usually 17 to 22. At 1 week of age, they should be about 15 to 20. And at 1 month of age, they're down to about 11 to 15. A low hemoglobin level is called a primary anemia, and causes of that could be a loss of blood, nutritional deficiencies such as not enough iron, B12, or folate, bone marrow problems, kidney failure, or abnormal hemoglobin such as in sickle cell anemia. High hemoglobin levels, also called secondary or physiologic polycythemia, can be due to chronic hypoxemia, dehydration, which produces a false sense of high hemoglobin that disappears when the patient gets enough fluid, or excessive epogen administration causing production. Sodium supplementation helps the preemies gain weight following their initial postnatal diuresis. Normal sodium levels in a neonate should be 135 to 145. Hyponatremia, which is low sodium, causes an osmotic shift of water from the plasma into the baby's brain cells. So severe or rapid hyponatremia can result in cerebral edema and neurological damage. Hypernatremia, high sodium levels, can manifest with CNS involvement, causing parenchymal abnormalities, hemorrhage, or hemorrhagic infarction. Potassium levels, normal levels are 3.5 to 5 milliequivalents. Hypokalemia, which is low potassium levels, can cause elevated blood pressure and cardiac arrhythmias, such as prolonged QT intervals. Moderate hypokalemia may cause muscular weakness, myalgia, muscle cramps, and constipation. Severe hypokalemia can cause paralysis, hyporeflexia, and respiratory depression. Hyperkalemia, or high potassium levels, may result in impairment of the neuromuscular, GI, or the cardiac system and can cause VFib and asystole. Chloride levels is the major, chloride's the major anion in both the blood and our extracellular fluid, and the amount of chloride in the blood is controlled carefully by the kidneys. It keeps the fluid levels inside and outside of the brain cells and all cells in balance. It maintains the blood volumes for the patient, maintains their blood pressure, and the pH of all the body fluids. And normal chloride levels should be 95 to 105 milliequivalents per liter. Significant increases or decreases in chloride can have bad effects or even fatal consequences to the patient. So hypochloremia, or low chloride levels, can be caused by excessive sweating, urine, and bile. Excessive loss can occur from sweating, vomiting, adrenal gland and kidney disease, or for administration of bicarbonate, from steroids, diuretics, and laxatives. And you will see this in a metabolic alkalosis. Hyperchloremia, or high chloride levels, can occur with diarrhea, certain kidney diseases, hyperparathyroid glands, or administration of hyperalimentation, ammonium chloride, steroids, and estrogens. So this would present as a metabolic acidosis. Ionized calcium is the calcium that's freely flowing in your blood and not attached to any proteins. This is the one we get on the blood gases. The normal is 4.5 to 5.5. Hypocalcemia in the ionized calcium. The patient may have some petechiae. They may feel like pins and needles of their extremities. They may have muscle spasms, hyperreactive tendon reflexes, laryngospasm, cardiac arrhythmias, prolonged QT, or STs. Hypercalcemia, or too much calcium, patient might have fatigue, depression, confusion, anorexia, nausea, vomiting, constipation, pancreatitis, or increased urination. Chronic hypercalcemia can result in kidney stones and abnormal heart rhythms, which can result in short Q and widened T waves. And severe hypercalcemia can result in coma and or cardiac arrest. Ionized magnesium. This is normal dependent on the gestational age of the baby. So 32 weeks is about 0.69, 33 to 37, 0.63. In the term, it's a little lower, 0.57. And then in adults, it goes back up higher again, 0.69 to 0.94. Magnesium acts as a physiological calcium blocker. So think of him as Dr. Magnesium. Low magnesium levels cause weakness, muscle cramps, cardiac arrhythmias, tremors, jerking, involuntary eye movement, confusion, hallucinations, disorientation, seizures, hypertension, tachycardia, depression. And hypermagnesemia, or high magnesium, can cause weakness, nausea and vomiting, impaired breathing, hypotension, hypocalcemia, arrhythmia, and asystole. The clinical consequences are usually related to the serum concentration. So if it's 4, it could cause hyporeflexia. If it's greater than 5, prolonged atrioventricular conduction. Greater than 10, complete heart block. Greater than 13, cardiac arrest. So glucose, which is the body's primary source of energy, normal value should be between 80 to 120 in adults and 60 to 100 in term infants. Hypoglycemia is low glucose, and the early symptoms of hypoglycemia can be caused by epinephrine release. So early symptoms you'll see are trembling, clammy skin, palpitations, anxiety, sweating, hunger, and irritability. Late symptoms are usually confusion, headache, seizures, coma, and death. So high glucose levels you will see during times of stress, such as inflammation and infection, and it's due to a catecholamine release that raised the blood glucose levels. Symptoms include being really hungry, excessive thirst, lots of urination, blurred vision, fatigue, weight loss, super dry mouth, dry and or itchy skin, recurrent infections, Kussmaul's breathing, and this can lead to cardiac arrhythmias, stupor, coma, and or death. The BUN evaluates the function of the kidney with the creatinine. It's used to monitor acute or chronic kidney dysfunction or failure, or to evaluate the person's general health, such as part of a BMP or CMP. Normals for children are about 5 to 18. But what do the test results mean? An increased BUN suggests there's impaired kidney function, which could be caused from excessive protein breakdown, kidney disease or damage, GI bleeding, a high protein diet, or decreased perfusion to the kidneys because of shock, or CHF, or stress, or dehydration. Low BUN levels are not common and are not usually a cause for concern. Usually, if you see them, it's due to severe liver disease, malnutrition, or fluid overload. Creatinine is also an indicator of renal function. We have increased blood creatinine levels when there is severe damage to functioning nephrons. Human reference ranges are 0.5 to 1 for females and 0.7 to 1.2 for males. So males tend to have higher levels of creatinine because they have more skeletal muscle than women. And last but not least on our electrolyte journey, we have lactic acid, also lactate. Lactic acid is produced by the starvation of skeletal muscles that are producing pyruvate. Two probable causes of increased lactate are a high energy demand of the patient with limited oxygen, such as anoxia and heart disease or lung disease, or an epinephrine surge that increases the skeletal muscle activity, aerobic glycolysis, such as people with intense exercise, patients with shock or sepsis. So initial high lactate levels are an indicator of the severity of the primary insult to the patient, and prolonged elevation is a better predictor of mortality than the initial lactate levels. So if it stays high over time, the mortality is worse than those who popped up high and came right back down. So there are differences in arterial blood gas values after birth at 5 minutes and 24 hours after birth. So 5 minutes after birth, the patient could be from 7.2 to 7.34 on their pH. And then 24 hours birth, they're going to be 7.35 to 7.4. CO2 levels 5 minutes after birth should normally be 35 to 46, and 24 hours after birth, 33 to 35. Going on, we have 49 to 73 in the PaO2 after birth, and then at 24 hours after birth, it's 72 to 75. Oxygen saturation should be about greater than 80% 5 minutes after birth and greater than 90 24 hours after birth. And then bicarb levels will trend up as well. Normal capillary blood gas values in infants are pH of 7.30 to 7.38, a PCCO2 of 38 to 48, a PCO2 of 40 to 50, which we usually ignore because it's pretty irrelevant, a bicarb of 20 to 22, and a base excess or deficit of -2 to +2. Cord gas values for the term in newborn: pH of 7.18 to 7.38, a PCO2 of 32 to 66, a bicarbonate of 17 to 27, a PO2 of 6 to 31, and base excess of -8 to 0. Normal arterial cord values in preterm newborns is a little bit lower or wider range. pH is 7.14 to 7.4, PCO2 of 32 to 69, bicarb of 16 to 27, and base excess of -7.6 to 1.3. The pH and the base excess are the main values examined by the medical team. A pH of less than 7.18 and a base excess of less than -8 are strong indicators that the patient was oxygen deprived. And research has shown a strong association between a pH of less than 7.0 with HIE, hypoxic ischemic encephalopathy, intraventricular hemorrhage, periventricular leukomalacia, and cerebral palsy. So that is why we focus on these numbers. We also have neuroprotective values for our elbow infants, and the goal CO2 levels while intubated in the first 3 days of life. Sorry, that says 4, but it's supposed to be first 3 days of life is 40 to 55. And days 4 to 7 are 45 to 60. And then at greater than 7 days, we go 50 to 65. I apologize that you will not be able to get CEs if you are only seeing this as